Hi, this is Nicole Kupchik, and I'm here with 10 Minute Tidbits. Today, I'm super lucky to be interviewing Dr. Bill Reed, who's been a cardiothoracic surgeon for 25 years. Hello, Dr. Reed.
Hello.
So he's super excited, you can tell, because poor guy, had to sit by me at the conference today, and I talked him into doing this interview. But actually, I think he's just being modest because he's got a lot to share with us. So you've been a cardiothoracic surgeon for 25 years.
Ish, right.
Ish, okay. Yeah. So do you mind telling, because the audience is mostly nurses, respiratory therapists, pharmacists, do you mind telling them what you've done in surgery?
So typically most of our cases are coronary bypasses. We do aortic valves, mitral valves, occasionally a tricuspid valve. We do maze procedures, we do aortic dissections, doing less thoracic surgery because we have specialists for that now.
Okay.
Yeah.
All right, so what is your top favorite surgery?
I personally like coronary bypasses.
The bypasses, nice. Yeah. Okay. Yeah. So can you just think back to the first time you ever did a bypass, how scary it was?
Yeah, I can remember.
I can't even fathom. So what's the scariest part of the surgery itself? Is it putting them on bypass, getting them off?
So to me, all of them is aortic dissections, where you have everything taken apart and then trying to put it all back together again. Yeah. And sometimes there's some wrinkles in there that you hadn't anticipated before the surgery. So trying to make that all work can sometimes be pretty tricky.
Fascinating, yeah, okay. All right, so you love doing bypasses.
I do.
Okay, so one of the things I wanted to ask is, how do you choose? Okay, so you know you've got a patient, let's say it's an elective, okay? So you're going to the OR, how do you choose what vessel you're going to use to bypass? So if it's saphenous vein or internal mammary or radial, how do you choose?
Right. So we always use the left internal mammary artery unless it's already been used in a previous operation or unless it's been injured by a previous surgery, something like that. But we always use the lima. Occasionally we'll use both mammaries if the patient's not a diabetic, he's not overweight, he's not a smoker. But the problem with using both mammaries is that you take 90% of the blood supply, so you increase the risk of sternal wound infection. So you want to pick the ideal patient. Otherwise, we use a lot of radial arteries, and I'm lucky enough to work in an institution that's pretty good at identifying people that have incomplete palmar arches. That is, that the radial and the ulnar artery communicate, so if I take the radial artery, you still get blood flow to the thumb. That's not always the case, and if you don't have a good ultrasound department, they can't always identify that. And then the saphenous vein is a very easy conduit to get. It's a very easy conduit to work with. In the last 15 years, we've been using endovascular harvest techniques, and that's much less painful for the patients.
Yeah, they don't have a big incision all the way up their leg.
Right.
Okay,
they don't have
nice.
wound healing problems, right?
Okay.
Yeah.
All right. So internal mammary. So what usually do you go Lima, LAD, and Rima, RCA? Or?
Lima to LAD is the usual case because the LAD is the most important vessel, so you want to put your best conduit there. Occasionally, you find somebody that has a diagonal vessel or a circumflex vessel that is the superior vessel, the more dominant vessel. So I might put the Lima to that one if that was the case.
Okay.
Yeah.
All right. So everyone's anatomy is a little different.
Exactly.
Yeah.
Right.
Okay. And then so you said if you do both IMAs, then you worry about sternal wound infections. So as a nurse, what should we worry about post-operatively taking care of these patients?
Well, sternal precautions, which the nurses are very good about teaching the patient how to take care of their breastbone, taking care of their blood sugars, making sure that their blood sugars are dialed in, and then making sure you have a compliant patient who's going to go home and take care of it. Guys are often the worst after 2 or 3 weeks.
Men?
After 2 or 3 weeks, they feel like they're in a brand new body and they want to go back out and play golf or shoot a gun or dig a hole or chop wood. So those are the
chopping wood with a sternal infection. Sternal wound. Yeah. That wouldn't be good, would it?
No, not a good plan. Yeah.
I love it. Okay. All right. And then, what types of patients make you go, oh, okay, this deep breath. Let's eat a good power bar before this one.
So reoperations are always more difficult,
especially
if they have previous grafts that are still in place that you have to get in and get around without creating problems. But then after that, aortic dissections, I think, are the ones that make me stop and think.
Okay, well, that's interesting to know. And really, so if somebody has an aortic dissection, not rupture, but dissection,
right.
What's usually the cause of that?
So usually they have an aneurysm, and then occasionally they'll have a connective tissue disorder. If they have an aneurysm that's over 5 centimeters, the risks go up statistically every year as it gets bigger.
Okay.
But if it's less than 5 centimeters, then they have a bicuspid valve, or they have a connective tissue disorder. They can actually dissect before the 5 centimeter mark or 5.5 centimeter mark.
Okay.
Yeah.
And then can you tell us the difference between type A and type B dissections?
So type A dissections involve the ascending aorta, and they put the coronary arteries, the aortic valve, and the whole heart at risk of being ischemic, or the valve can be disrupted and no longer work, so they can be life-threatening quickly.
So that's a surgical surgery.
Emergency.
Okay.
Right.
Mm-hmm.
Type B dissections are dissections that involve the descending thoracic aorta. They need good blood pressure control. They may not need surgical therapy, and they need continued surveillance to make sure that the aorta doesn't become aneurysmal over time.
Yeah, because you always hear like type Bs, we're going to medically manage them, and so blood pressure control. Where do you usually run a type B dissection? Where do you run their blood pressure?
So ideally, I'd like to see a systolic blood pressure of about 110. Some of it depends on age. Older people need a little bit more blood pressure. Younger people can tolerate a little bit less.
Okay.
So I usually want to try and focus on keeping them under 110 or 120 if possible.
Okay, and what drugs do you like to do that?
So beta blockers are the best because they decrease the force of contraction, so it decreases the stress the aneurysm is exposed to. So
I love that. I hadn't thought about it that way, but they're negative inotropes.
Yeah, right. So
love it.
Esmolol is the best infusion, and then we switch them over to oral beta blockers of some kind.
It's like metoprolol or
Lopressor, yeah.
All right. And what do you think about like nicardipine and maybe Clevoprex or calcium channel blocking medications?
We're using a lot more of them recently. In fact, Teresa was telling, my wife as a nurse educator, was telling me that we're using the benefits of the calcium channel blockers. They're seeing more myocardial remodeling in patients that have had LVH and things that have developed over time. So we're starting to use more and more calcium channel blockers, but I don't have quite the same record with them that I do with beta blockers.
Sure, those are kind of just a good go-to that we're used to. Okay. Right. All right, and so are there any tidbits that you would say, or any things that you would want a nurse to know about taking care of either your dissections or your post-CABG patients? Like, and we're going to talk about post-op care in our next segment, but is there anything like immediately post-op we should just be on our toes about?
So when I first bring a patient back from surgery, the first three things I'm worrying about are, number one, are they bleeding? Okay. If they are bleeding, do I need to do something to correct that? Do they need factors, or do they need more protamine? Number two, I worry about blood pressure and hemodynamics. Do I have a satisfactory cardiac output? Are there markers of end organ perfusion satisfactory? I mean, are their lactates okay? Their SEO2 okay? And then the third is the glucose. Do we have the glucose control dialed in? Do we have an infusion going? Things like that.
Okay. And how tight do you run these patients in general?
So we used
glucose-wise.
Yeah, we used to run them pretty tight, but I think in the last 5 or 6 years we've loosened up a little bit. We'll let a blood sugar up to 180. We prefer it under 150, but up to 180 is considered acceptable. But I really don't like seeing them go above that because it increases the risk of sternal wound infection.
Sure. Okay, that totally makes sense. All right. Well, this is fabulous. I mean, like, how great is it to sit and pick the brain of a cardiothoracic surgeon? This is absolutely amazing. So, anyway, all right. Well, we're going to do another segment. We're going to talk about post-op care of cardiac surgery patients in our next segment. So, I want to thank you. I think the nurses and RTs, pharmacists are going to love this.
Okay. Well, thank you. Yeah.
He still is a little reticent about this. I love it. So, anyway, this is Nicole Kupchik, and this is 10 Minute Tidbits.